everything is going to fit. So the way that drugs like colistin have been used in kgs in poultry feed and cattle feed, it's really, really very harmful. And now we are getting a lot of foods which they specify that they are unadulterated, they are antibiotic free and all these things. I don't know how much true is that, because ultimately they have to feed with the antibiotics, and ultimately the antibiotics they come to us also. And when we did multiple studies, and I'm talking about UCMS back in 2010, we did a study, and we found that at least 10% of the normal population, they are harboring the carbapenem resistant bacteria in their gut flora, and that was in 2010. So now if we do a random study, probably it might go on 25-30%, even more than that. And it's known, most of the clinicians would know that many times the infections are caused by the autologous flora only. That's why. So that will be my area of interest, I would say. I won't say expertise because I'm still learning. And when it comes to the philosophical part of it, I always say that we humans behave just like bacteria. Because we are made of 35 trillion cells, at the same time we are made of 350 trillion bacteria also. So we are more bacteria than humans. Why? Because the way that we say that खरबूजे और एक खरबूजा रंग बदलता है. Similarly, you keep two people in the same vicinity, they will learn from each other. They'll take a plasmid from each other, like the bacteria do, like just like that. So they imbibe good or bad properties depending on what is the predominant one. Second very interesting property that we behave like bacteria is like when you put a bacteria into a medium, so it will sense the pH, it will sense the temperature, it will sense the proteins, it will sense the carbohydrates, it will sense the oxygen content. So accordingly, it's in a quorum sensing phase. So when they say that okay now it's 35 degrees, it's ample amount of protein, so it will keep on start multiplying and dividing and go in a log phase. Similarly, like I have shifted from North to India to South India. So initially it took me time to realize, okay, now I'm in a new place. What is the predominant food? It's a South Indian food. Idli dosa sambar milega, aapko chole bhature yahan pe nahi milenge aapko. So accordingly, you take time in adjusting. You take time in learning a new language. You take a time in adapting to a new set of environment. So same way you grow and multiply. You learn a new language, and then so it's like this, like that. So what I feel that yes, when it comes to preventive medicine. The natural foods in Ayurveda definitely has got a very significant role. When it comes to actual cure in the acute phase, that may not work. And when it comes to the customized medicine, so as we say that I cannot wear his shirt, he cannot wear somebody else's shirt, it's always tailor-made. Similarly, all the therapy is tailor-made. So what we do in our institute is that whenever we are prescribing any antibiotics on an AST report or antimicrobial susceptibility testing report, we always customize our report. We just don't blindly say that, okay, I've tested for 30 antimicrobials, I'll report all 30 of them. So whenever we are reporting, we customize, we see the patient's age, patient's weight, patient's sex, creatinine clearance. So we have our why we call it integrated stewardship lab is because we are integrated with through our HMIS, we integrate with the pathology department and biochemistry department. So we see the TLC count, the DLC count, the multiple parameters, the PCT count, the ESR, everything we correlate, and then we'll see whether what I'm reporting is really a true pathogen or not. Whether this patient really requires an antibiotic or not. Then our residents will go and take a site visit, they'll go to the patient's website and they'll check whether the patient is really symptomatic or not and the other parameters are correlating or not. That is how we integrate all this information and then we customize the report. Okay, now in this case, this is the bug, these are the drugs, this is the drug which are already been given to the patient, and because of the nature of this particular bacteria, it is likely to become resistant during treatment. So these are drugs which I am not supposed to give. So accordingly, customize the antibiotics to be given to the patient or not to be given to the patient, whether it requires systemic antibiotics or oral antibiotics or local antibiotics. That also we are customizing everything. And then let's say if it is a systemic infection, a bloodstream infection that requires systemic and parenteral antibiotics, in that case we customize the dose also. We make a chart known as what you call the breakpoint to MIC chart, DMQ quotient chart we make, and that is that I can say that with a lot of information that we are the only lab that we are routinely reporting the breakpoint to MIC quotients, a concept that is not known to most of the clinicians because जब रिपोर्ट जाती है तो कई बार क्लिनिशियन पूछते हैं बताओ उसमें कौन सी एंटीबायोटिक देनी है, कौन सी मोस्ट इफेक्टिव है, राइट? दैट्स सम ऑफ दी who are doing little bit of introspection, they would ask that okay, which one to give. So in that case, we do that calculation for them by certain mathematical calculations. We do that calculation for them based on the MIC, and then we tell them if you're supposed to give amikacin or gentamicin or piptazo or ampicillin. So in what sequence, in what dose, and in what is the antibiotic posology, how you're supposed to give the drug. So that kind of ultra customization we do for a patient when it comes to giving the antibiotics. And then once the report goes to the ward, our residents will follow up the report and do the prescription auditing also. So that is the level how we follow. So we are trying to customize, or you can say tailor make each and every report as per the patient requirement. And we follow it up also. So that is what we are attempting over here. Same thing goes for other also, like if you talk about mycobacteriology also, whether what we are seeing as an acid fast bacilli is it related to pathogen or is something else. So everything is followed up. So now we have got ultra advanced machines like the Marditop, we got a CLIA machine, we got CBNet also. Now we are able to acquire the newer machines like the automated media preparators also, the BioFire. So we are going to upgrade slowly.
Is that scalable?
Sorry?
Is that scalable?
Scalable in the sense?
Can it be applied to other hospitals and setups as well?
Yeah, you see, actually, I'll give you another example. Like when we were doing our MD, so that time there used to be seniors' notes. कि इसको पढ़ लो पास हो जाओगे. So that means you're not supposed to use your mind. And that puts a full stop into your thinking process. As humans, we are supposed to think. We are meant to think. That is why we are incarnated. तभी हम लोग व्यक्त होते हैं. तभी हम लोग व्यक्ति बोलते हैं हम लोगों को. Because we are incarnated. So we are supposed to think. So if you give the knowledge, tell them to think. Okay, this is supposed to think. You can scale it to other labs also. This is not something that I have something I've copy pasted from somebody else. Simply because you think, you can scale it to different labs. Same thing can go for pathology also, for biochemistry also, and for other institutes also. You can integrate. You can do integrated reporting, and that is why you have to have a lot of digitalization is required when it comes to connection of all the labs. It should not be I will not share my data. No, that's a very critical thing to do. You have to share data.
Very important point, sir, said that I will not share my data. This syndrome, this is something knowledge sharing across D to D, especially, so doctor to doctor is so very important. I would also like to bring this point, sir, that very often I see in the local hinterland that third generation cephalosporins, they are prescribed quite, liberally. So the guidelines, as you mentioned, the protocols, so at AIIMS we are always been taught that, give the first line of drugs, then then the second line, then the third line. So some kind of a CME or a continuing education, or this kind of a cause needs to be addressed or not. What are your views on this, sir?
So who decides what's going to be the first line drug, what's going to be second line drug? It is for the microbiologist who has to do that. Why? Because we maintain our data in real time. We maintain our entire AMR data, antimicrobial resistance data in real time. So if you ask me as of today, because we are digitalizing all the reports, everything is digitalized. So if you ask me, what is the percentage of MRSA in surgery ward that belongs to Dr. Rajshekhar Mohan, for example? So you put up multiple strata on your data, and I can give you that data also. So again, I say the same thing. If you can customize and digitalize your entire AMR data, you can come up with a customized antibiogram for that hospital. You don't need to copy paste it from ICMR, you don't need to copy paste from Stanford guidelines or Johns Hopkins. You have your own data, because we have again proven that drugs like azithromycin may not work for Salmonella typhi in India, because the resistance is higher, the overall MIC levels are higher, the epidemiological cutoffs are higher, so it may not work. So blindly copy pasting Harrison or Davidson is not going to be sufficient. We have to have our own data.
So precisely, this is such an important, I think, facet. Dr. Arun, sir.
No, basically, I think I would give a hand and a foot for the type of reporting you are describing in terms of advising the clinicians about which drugs in what sequence and all. But I believe we do get sensitivity reports, but beyond that, the decision making is totally left to us clinicians and most of the hospitals.
So it's not just the report, we also tell that, okay, if I have isolated the Enteropater cloacae, so now this means that this particular bacteria is going to immediately become resistant the moment you add a drug like an amoxiclav or imipenem or third generation cephalosporin, because that is inducing resistance.
Yeah.
So it is not like if you got E. coli and Klebsiella, it is the same as Proteus, it is the same as Proteus vulgaris, the same as Proteus like that. So all the GNVs are also different. The gram-negative bacteria, they're all different. You can't equate Enteropater cloacae, even amongst Citrobacter, for example, Citrobacter frundi is different, Citrobacter kozeri is different.
Yeah.
So which is why we need precision medicine when it comes. That's the reason why Multitops helps us so much, because Multitop will tell you precisely what is the exact bug. So if I know that Enterobater cloacae is there, I will not report amoxiclav, I will not report third generation falciparum on my report. I will not do, because I know that the moment you give a choice to the clinician that okay, third generation falciparum seems to be a palatable choice for me, so let me start with that. So that's going to create resistance. So we don't give that choice to the clinician.
So I think what Dr. Anju was saying, how this sort of reporting can be disseminated to all the other sort of
Precisely.
centers.
Perhaps the Ayush Tech group at IIT Bhilai and AIIMS Raipur would be doing a specialized AI model around what integrated stewardship laboratory is doing. Because going to that depth of pathology is something which this laboratory has really brought about.
Microbiology and that's very very important, sir. I think this is something food for thought and take away from this
And
discussion.
while we are closing it across, because a lot of doyens in the surgical space, in the space of eye care, cancer care, what kind of a preventive strategies you would like to initiate from this forum on this International Day of Arogya? Because Arogya is all about freedom from disease, that is the highest level. So the secret tips, like how to prevent these.
I would also like to welcome Dr. Satinder Kaur. She's from the Gynec-Onco Surgery Department at Max Vaishali. And has joined us. So, Dr. Satinder, you may also share your views.
So, first of all, Dr. Vinay Garodia, perhaps eye care, the
Sir.
preventive health,
Sir.
कि जीवेम शताधिकम वर्षम, जो भारत की एक बात रही है, जीवेम शरदः शतम, पश्येम शरदः शतम, बुद्धेम शरदः शतम, रोहेम शरदः शतम, पूषेम शरदः शतम, भवेम शरदः शतम, भूयेम शरदः शतम, भूयसी शरदः शतम. So in that spirit, while we are coming to the close of this intellectual deliberation, so your tips on Pashyem Shraddha
I
Shatam.
think before I come to eye care, the fact that it's being done on Yoga Day, that itself is a preventive. The yoga itself, it's like everything aspect of it. The exercise part of it, the diet part of it, the living part of it, that itself is preventive. And when people used to say that this government has not spent too much money on health budget, and I would often say that the money that the government is spending on clean water, on sanitation, on providing the gas cylinders, all those things are actually health budget.
Yes.
Having much bigger impact than opening up a few tertiary care hospitals. This is much bigger thing that the government is doing. So the biggest preventive aspect is to take care of the overall society. And even as Sir pointed out, by making better infrastructure, letting the doctors go to the periphery. So each and every aspect of these works are actually health budget. So that is all having preventive aspects. Coming to eyes, I would say most of it would be because I, being a retina person, I see a lot of patients with diabetes who come to us very late. So there's a whole lot of health education that has to be given. So a lot of health education to the patients, and some platforms can be used. In fact, why not to have a whole repository of all the diabetics in the country? The database should be there with the government. And on a regular basis, they should be sent an SMS or something to say that, okay, you require an eye care, eye checkup, you require a kidney checkup, and all those things. All the information is provided to them on the basis of their language that they know. The government knows which country, which part of the state they are from, and then which language. So all that kind of repeatedly this thing, and then again linking it to their Aadhaar ID, making sure they're getting a reminder to get a retina checkup every 6 months, all the other things. So I think we can use technology in a very, very big way in this preventive aspect. So that's what I would say.
Thanks.
Because we give so much of importance to cataract, unfortunately. People come to me and ask me, Dr. Sabra, cataract to yoga. I say, I don't even look at cataract. Because if you develop cataract, then I have got, whether you have symptoms, after that I've got a few months within which I can operate without any problem. What you should be concerned about, doctor, I've got diabetes, I've got a retina check, because that's where people come late to us. For retina problems, people come late to us, and they're only bothered about cataract because that is where all the publicity has gone in so far. So for those irreversible vision loss things is where I would like to put more emphasis rather than things like cataract or even for that matter glasses removal, which is fine. It's a very good financial thing for us, but it doesn't really make too much of a difference when it comes to controlling the blindness. So I think that emphasis has to be there. Yeah.
So also pertaining to eye care, something about the preventive aspects, how would you like to throw light on this, that how eye problems like, community healthcare eye problems, especially like trachoma and glaucoma and various eye infections. Create an awareness at an administrative, state level, community level. So if you could also.
So again, I think the trachoma part, that the amount of trachoma we used to see earlier has gone down significantly. And not because we ophthalmologists did anything. It's just because of better sanitation,
So,
and that has made all the difference. So that further proves my point that you don't have to actually look at the doctor's level, but you can work at the community level to make the changes.
and a lot of glaucoma patients I'm seeing in Uttarakhand.
Yeah.
If we, it's important to go to the etiology also. It's very often drishti is there. I wish we next iterations we would. In Uttarakhand we have various eye hospitals, but how we can address the root. How to prevent. Something about that. Are there any causes which are preventable? What the government at government level, Niti Aayog and
More than prevention, it's the early detection which is more important.
Early detection.
Glaucoma and all these things. So
So-
again, going back to education and having a database, so if you can have anyone above 40 or 50 years in age should be getting a regular eye checkup. Or if you have a family history, then it's flagged up that okay, you are more at a risk for these things. So I think ultimately using data and education. These are the two most important aspects for ophthalmology that I can think of.
I think Dr. Garudia has opened up another yoga, the yoga of good governance and good health, like good sanitation, clean water. It is doing the preventive part on its own. Maybe we pass on to Dr. Arun Kumar Goel, sir. The cancer is really spreading like an epidemic, and perhaps it has caused, from the nutritional perspective also, there are dimensions of it. So, sir, please enlighten us.
When we talk of say preventive aspects in cancer, so again we talk at three levels as we were told: primary prevention, secondary prevention, tertiary prevention, and all. So primary prevention, it is all very well known that 90% of cancer is related to environment. It's only 10% which is some hereditary component. 2 or 3 major things. One, about 1/3 of world's cancer is related to tobacco. Now, how do we eliminate tobacco from our lives? It's a moot question because there's so many commercial interests for the companies which sell tobacco, government which gets lot of taxes and all, and people who say we have the freedom to choose whether we go for anything which is addictive and all. But 1/3 of cancers can be prevented. So the only thing we can do at our level is at least we become examples or role models for our families and try to sort of give a message to others. So other than tobacco, definitely we have things like one is weight and physical activity. So being overweight and being sedentary, it is supposed to be, you say sitting is like smoking. So another big chunk of cancer is related to being either overweight or being very sedentary. So if you have a weight within your normal range and have regular exercise activity, again you can control a big chunk. The third part comes related to viral infections. So we have cancer cervix, which is related to human papilloma virus, liver cancer, which is related to hepatitis virus, and few Epstein-Barr virus for some of the cancer. So we have vaccines available for HPV and hepatitis B. So at least those two vaccines being integral part of the vaccination programs. So, and definitely there are other things about sexual hygiene, barriers which prevent spread of infections and all. Other than that, definitely the other element is lot of chemicals which are sort of used in food processing, pollution within the air and all. That again is a large part of what causes cancer. So definitely we can prevent a large chunk. Only thing is nothing is going to happen overnight. Cancer develops over decades, and any preventive effort will work over decades. So we have to have a very long-term view. The second thing is in the short term you have secondary prevention, that is identify pre-cancer lesions and sort of do something to treat them, maybe leukoplakia and all. The third part is tertiary prevention or delay in diagnosis. I think I would share something. We have carried out a study. I did once when I was at AIMS, that was in 90s, and once I did it in maths for breast cancer. So the delay in breast cancer patients from the time that the patient first notice symptom to the time they come to us for treatment is about 8 to 10 months average. And there are patients who are into sort of many years from the time the symptoms started, and we notice that half of the delay is happening before the patient, at the patient level, before they come to any doctor, and half of the delay is once they have actually been in contact with the healthcare system. So we need to work at both levels. So the public awareness has to be there, that public either is not aware, or the other component is fear. They think that I go to the doctor, he is going to diagnose cancer, and they think cancer is a death sentence, so why hear the death sentence today? And the second part is that when the patient goes to a doctor, so there are so many people within the healthcare system who are not sort of focusing on cancer diagnosis. For breast cancer, like patients often go to their gynecologist rather than a surgeon or a breast specialist. So gynecologist, what we noticed so many times, they are not even examining the patient and all. So these things are like, we have to work on sort of educating our healthcare professionals also. So that early diagnosis is a very sort of important factor. Stage 1 cancer, you have 95% cure rate. Stage 3 cancer, the cure rate is 40-45%. So these are the sort of components which I can say in a preventive form.
I think we have a gynec onco amongst us, Dr. Satinder Kaur. Perhaps what Dr. Goyal talked about, this entire, I would say, conundrum which we have in the space, like women visiting their gynacs but not getting their, I would say, the oncology part of it. Also, I would request perhaps Dr. Satinder Kaur to join in on the stage and also inform, because this is the 50% of the. Yeah.
Ma'am has a word actually, ma'am, to say. Yeah, so, ma'am, we seated for a while, ma'am, please.
Space for him.
There's a space
Yeah.
there.
But I think when one comes that, like to say, that Dr. Hemlata's role is very similar, that if we can reduce obesity rates, if we can, tobacco at least is being taxed, at least we're talking tobacco as being toxic. We're not willing to tax Coca-Cola, we're not willing to tax sugar, we're not willing to, sugar should be as heavily taxed as tobacco. Just at one point here, 56.4% of the disease burden is because of unhealthy diet, while tobacco contributes to 30%. That's what, ma'am. And tobacco, ma'am, at least it's thought of as toxic. Kuch meetha ho jaye to is a positive thing. So nobody's even looking at it societally as an evil.
So, Dr. Satinder, please.
So I think you want me to discuss about prevention of gynecological cancer?
Yes.
Yeah. So when we talk about gynecological cancers, you're absolutely right. The most important thing which is lacking here is awareness. And awareness is not just amongst the general public, it is amongst even the doctors. Like half an hour before me, a head and neck oncologist messaged me what is the right age to get a pap smear done, 30 or 40. So that was her question. So that means a head and neck leading oncologist and trained along with me in Tata Memorial, I would say. And now she is 15 years into practice, but she is a head and neck oncologist and is not aware of when to get a pap smear done. So gynecological cancer, if you talk about cervix, which is the #1 cancer at this time, the mortality rate is very high in India, not worldwide. Worldwide, if we talk about other countries, Australia have reached a level of eradication of cervical cancer. Because this is one cancer we know which can be easily prevented, for which we have a vaccination also. But the problem which is there in our country is, I will again not say it's not the government which is the cause, which everybody says, because government has not put it in national immunization schedule, that is why vaccination is not being done. I think that's not the case. It is just the awareness. We ourselves most of the people are not aware about it. Even the doctors are not aware about it, that there is a vaccination and this vaccination doesn't have any side effects and it should be prescribed to all children. Most of the times, and there is a lot of fears, misconceptions about the vaccines which lead to that even the doctors are not prescribing. And when the doctors are reluctant in prescribing, how do we expect the general public to come and take it? The cost is not an issue for Indian public. I don't feel that thing. For majority of the people, they can afford the vaccines. Then screening, which is easily available for this cancer, which has been there since many years. Government had introduced pap smear in the screening program in 1975, but till date the screening rate is less than 3% in India. So and it has to be done once in 3 years. And as sir was talking about ophthalmology and including that AI in it, and we get the regular messages. Even for our car service, we'll get a message, it's been 6 months here, you have not got your car serviced. So if we get that message, every female in India gets a message that it's been 3 years, you have not got a pap smear done. So I think if they get that message, at least maybe even yearly if they get it done, so get the message, once a year they get the message, at least once in 3 years or 5 years that they'll get it done. WHO says even if they get the pap smear done twice in your lifetime, you can bring down the rate drastically of cervical cancer. So this is the main thing. So if getting a pap smear, a simple test done, which is an OPD procedure, twice in lifetime is one which is needed to bring down the incidence of this cancer drastically, but we are not able to achieve it. We are still, the rate of getting screening is less than 3%. Then, if we talk about other ovarian and